Thank you, Bert. At this time, I would like to ask the image panel members to take their seats on the stage. And now, Dr. John Eng, Chairman of the Refresher Course Committee, will introduce Dr. Ronald Zagoria, this year's Image Interpretation Panel Moderator. Dr. Eng?
Thanks, Rich. In 1939, during RSNA's 25th annual meeting, a new refresher course called the Film Reading Session was introduced into the Sunday afternoon program. In that new refresher course, the attendees were invited to bring challenging cases for diagnosis and discussion by the attendees of that course. We fast forward to today, our 102nd annual meeting, where I have the privilege and honor to introduce our 78th annual imaging session by introducing our moderator, Ronald J. Zagoria, who is currently Vice Chair of Clinical Affairs, Chief of the Abdominal Imaging Section, and Professor at the University of California, San Francisco. Dr. Zagoria received his bachelor's degree from Johns Hopkins and his medical degree from the University of Maryland, and I believe this picture was taken when he was a medical student from those days. He did a residency and fellowship at Bowman Gray School of Medicine, which eventually became Wake Forest University. He joined the faculty at Wake Forest and rose up the academic ranks to eventually become professor and interim chair at the Wake Forest University, and before heading out west to take his current leadership positions at the University of California, San Francisco. He's well published, countless articles, book chapters, has been invited hundreds of times to speak at both national and international venues. He's served multiple national educational leadership positions, including president of the Association of Program Directors in Radiology, chair of the RSNA Refresher Course Committee, chair of the Radiology Residency Review Committee of the ACGME, president of the Society of Uroradiology, now the Society of Abdominal Radiology, and he is currently editor-in-chief of Emergency Radiology. Now, you can't accomplish all this without having help, and Ron says that his wife of 33 years, Kat, has supported and encouraged him throughout his entire career, and they also have two wonderful sons, Michael and David. Ron says that as a radiology resident, he dreamed of speaking at a RSNA refresher course someday, and well, he eventually did that, and in fact, he's done that every year for the past 29 years. I don't know if he ever dreamed of moderating RSNA imaging interpretation session, which he's about to do. So please join me in welcoming Dr. Ronald Zagoria, our moderator for tonight.
Well, thank you very much. My name's Ron Zagoria. I appreciate the nice introduction. It is absolutely an honor and a pleasure to be presenting here. It was absolutely a dream of mine to someday give a presentation at RSNA, and here I'm the moderator of the panel. It's an exciting event. However, this really isn't about me. This is about the panelists, and I want to tell you a little bit about the ground rules and about the panelists. So the panelists we have this year are all renowned, wonderful diagnostic radiologists. For pediatric radiologists is Ellen Chung, who represents the AFIP and the AIRP. She's at the United States Uniform Health Sciences Center. In neuroradiology, Nancy Fishbein from Stanford University, and I'll tell you more about each of these individuals as we go along. John Leyendecker, a former colleague of mine at Wake Forest, who's now at the University of Texas Southwestern, will be the abdominal imaging expert. For musculoskeletal radiology, Christian Fearman from the University of Zurich. And for thoracic chest radiology is Gautam Reddy from the University of Washington. So when I was in the audience, I often wondered, how do people figure out these cases? Is this rigged or is this for real? So this is how we did it, and there is nothing hidden here. So I'm going to pull back the curtain. I selected 5 world-renowned radiologists who were leaders in their field and well-known in the field of radiology. I selected very difficult, some might say impossible cases that would be interesting to discuss, and I got help from my experts at UCSF, section chiefs and colleagues, and picked really great cases. I hope you'll agree. I sent the cases to these panelists about 5 months ago, so they've had these for a long time, but these are tough cases, as you'll see. I did contact the panelists about a month ago just to make sure they were on track, but to be honest with you, they did not need any support. I've never given them the answers, but as you will see, these are truly experts. This confirmed that these panelists were, in fact, superstars. As a matter of fact, I will tell you, when I sent these cases out, I hit the send button on my computer to mail them out to each of the individuals. Within about 5 milliseconds, one of these panelists had already responded to me that they figured out one of the cases. It was quite amazing. But you'll see how they figured them out, if they did, as we go along. I do have to thank my colleagues at UCSF, Chris Hess, Thomas Link, John McKenzie, Brett Alliker. They're all section chiefs of their respective sections. Mike Oliger and Spencer Baer are also in abdominal imaging, and Ron Aronson, my chairman and former president of the RSNA. Thanks very much for all the help. Okay, ladies and gentlemen, let's start your motors and we'll get started with this. Okay, the first case is for our pediatric radiologist, Ellen Chung. And let me introduce you to Ellen. Here's her picture. She got her bachelor's degree from Georgetown University, as well as her medical degree from Georgetown. She did her radiology residency at Tripler Army Medical Center, and then did a pediatric radiology fellowship at Boston Children's Hospital. She's an associate professor and vice chair at the United States Uniform Health Sciences Center. She's chief of pediatric radiology at the AIRP, which I think was formerly known as the AFIP when I went there. She has published many articles and books, and I'm not going to go into detail. All of these panelists are well-authored presenters. So the first case, we don't give much history here. This is a one-day-old female. Ellen, it's all yours.
All right, so initially we have a radiograph of the chest and abdomen in this one-day-old female, and on it we see several tubes and lines. Also notice that their bowel gas is pushed towards the center of the abdomen, although not equally from both sides, more on the right where the yellow arrow is. Notice also there are bulging flanks and small bell-shaped thorax. Next image I was given was this barium enema, or contrast enema, which is notably normal. Then an upper GI series was performed. The most important finding on any upper GI series in pediatrics is the location of the duodenal-jejunal junction, which you can see indicated by the yellow arrow is in the left upper quadrant where it should be. There's no dilated bowel shown, but you can see that there's a large mass effect in the center of the abdomen that's just pushing the other bowel aside, as shown by the asterisk. Now, a CT was then performed, which shows that there are cystic areas, some of which appear tubular and some of which have some septations in them that are pushing the bowel aside. So the air and contrast-filled non-dilated bowel is indicated by the yellow arrows. And this coronal reconstruction shows that some of these appear tubular and they may have folds within them, as shown by the yellow arrows. So our findings so far is we have a small bell-shaped thorax and bulging flanks with displacement of non-dilated bowel centrally but not equally from either side. So initially I thought this might represent autosomal recessive polycystic kidney disease, in which case there would be 2 masses, both the kidneys, but that is excluded because there's only 1 mass. Contrast enema showed a normal colon. Upper GI series shows mass effect on non-dilated proximal bowel and a normal position of the duodenal-jejunal junction. And the CT shows multiple fluid-filled structures between the bowel loops that have some folds or septations in them, and some of them appear tubular. So based on the appearance on the imaging, the CT in particular, I thought perhaps that these were bowel because they're tubular and have folds in them, in which case the differential would include distal bowel obstructions. So I considered ileal atresia, meconium ileus, obstructing ileal duplication cyst, all of which would have a microcolon. A much rarer consideration, which also has microcolon, is megacystis microcolon intestinal peristalsis syndrome, hypoperistalsis syndrome, also known as Burden syndrome. So since we don't have a microcolon, these are all excluded. So other more distal obstructions we could consider would include colonic atresia. Colonic atresia should have a dilated loop of proximal colon and a partial microcolon. Functional immaturity of the colon, which is seen in infants of a diabetic mother or mothers treated with magnesium sulfate. That would show a transition zone from a normal distended colon to a small left colon at the hepatic juncture, or splenic flexure rather. So that was not present on the enema. Anorectal malformation is clinically obvious because there's no anus, so we would not have a normal enema. Another consideration is Hirschsprung disease, which can have an initially normal enema because it can take some time for the transition zone to develop and may not be present at birth. But it would make no sense to have only dilated proximal bowel and not some dilated colon in this case, so that's not likely. Very rarely, malrotation can cause a closed-loop distal obstruction due to LAD bands. So that's a possibility in this case, but as we noted in the upper GI, there's a normal duodenal jejunal junction, and so this is not a case of malrotation. So this left me with a differential diagnosis of nothing, which was disconcerting. So then I thought, maybe it's not bowel at all. Well, why isn't it bowel? If you think about it, there's no dilated proximal bowel. So if it's a distal obstruction, we should have some dilated proximal bowel. No contrast ever fills any of these tubular structures, and contrast was given from above and below. And those folds or septations are rather thick, perhaps more than we would expect for a bowel fold, and they're not very close together. So if it's not bowel, what is it? Well, perhaps it's dilated primordial lymph channels with no connection to the central venous system. And if that's the case, then my diagnosis is lymphatic malformation or lymphangioma of the mesentery.
Okay, thank you very much, Dr. Chung. Brilliant description of this. In fact, this case was diagnosed by laparotomy. It was very difficult for the pediatric radiologist to figure this out, and the correct diagnosis for this is exactly lymphatic malformation. There are numerous other names for this. You can see this list here: cystic hygroma, lymphangioma, cavernous lymphangioma, cystic lymphangioma, lymphangioma circumscriptum. This is the imaging features of this is that it's usually multicystic. There often are fluid levels. You may see hematocrit levels within these cystic areas. There can be flow or enhancement in the walls, the septa, and microcystic portions. Mesenteric lesions tend to encase the bowel, as you saw here, and it can obviously mimic bowel that's obstructed. It may torse and may hemorrhage, causing symptoms that require treatment. It is possibly associated with chylosocites in some cases. It's often classified into three subtypes: macrocystic, microcystic, or mixed variety. That's mainly important for the selection of treatment. And the treatment is generally sclerotherapy or surgical resection. And in this case, it was surgically resected. So bravo, Dr. Chung. We got off on the right foot. Okay, the first neuroradiology case will be discussed by Nancy Fishbein. Here's a picture of Nancy. She got her bachelor's degree and medical degree from Harvard University. She trained at UCSF with her diagnostic radiology and neuroradiology. Unfortunately for us, she's moved on to Stanford in 2004. She's a professor of radiology and, by courtesy of otolaryngology, HNS, neurology, neurosurgery, and radiation oncology. She's very accomplished and well regarded. She has many peer-reviewed articles, books, multiple book chapters, and she's a senior editor of the prestigious AJNR since 2011. Okay, the first case, neuroradiology. You can thank Chris Hess for this. 60-year-old with altered mental status developing over 2 weeks. Urine was positive for cocaine, CSF shows lymphocytic pleocytosis. It's all yours.
All right. Thank you very much, Dr. Zagoria, and thank you all for being here. And I certainly will thank Chris Hess when I find him, but I think he's probably gone to Costa Rica for a couple of weeks or something.
Hiding out.
Anyway, so my case has a little more history than Ellen's, and so I'd like to start with a discussion of the history. So my patient is a 60-year-old with altered mental status developing over 2 weeks. And so this leaves us with some very broad considerations, including the possibility of neoplastic disease, perhaps CNS lymphoma or an infiltrating glioma. Paraneoplastic is also an option for subacute alteration in mental status. The potential for an infectious etiology, for example, an atypical meningitis would be a consideration. Perhaps we're dealing with something inflammatory or demyelinating. We may be dealing with a vascular condition. I've seen patients with elevated intracranial pressure from dural AV fistula who present with subacute onset of altered mental status. And of course, in neuroradiology, we're always thinking about vasculitis. In fact, in all of radiology, we're always thinking about vasculitis. Trauma is another consideration, though probably too straightforward for this film panel, but nonetheless, a subacute or chronic subdural could have this presentation, and certainly the possibility of something toxic or metabolic. The urine is positive for cocaine, which is probably relevant since the information has been provided, but not necessarily. And then the CSF shows a lymphocytic pleocytosis, which definitely ups the ante for infection or the possibility of an inflammatory or demyelinating condition. The first image that I received was a non-contrast head CT, and I think that we could sit here and argue about whether the CT scan is absolutely normal or whether there may be, some scattered little subtle areas of patchy white matter hypodensity. But I think what we can say is there's no subdural hematoma, there's no cerebral edema, there's no intracranial hemorrhage. So we're not seeing any of some of the things potentially on our differential diagnosis. Clearly, we need a better look at the white matter, and there's no question that for white matter, MR is far superior to CT. So indeed, we are now given some images from an MRI, and this patient has multifocal white matter lesions. When we look at the FLAIR and T2 weighted images, we see these multiple ovoid lesions bilaterally within the cerebral hemispheres. They do have a little bit of a periventricular distribution and somewhat of a perpendicular orientation toward the expected position of the ventricular surface. On the T1 weighted image, these areas are mildly hypointense. So at this point, what do we think about? And I should also mention that I didn't include a gradient echo that I was sent, but there were no areas of magnetic susceptibility to suggest blood products, and we know from the CT scan that there aren't any calcifications. So with regard to some of the considerations from our differential diagnosis, we're still potentially dealing with ischemia, the possibility of small vessel disease in the white matter, multifocal infarcts, and vasculitis is not excluded. The possibility of inflammation, and in particular demyelination, with multifocal white matter lesions with this perpendicular orientation to the ventricular surface is absolutely possible. We could still be dealing with infection. We could be dealing with multifocal cerebritis, the possibility of septic emboli. Some of these lesions almost look like they have little tiny centers within them that could suggest the possibility of microabscesses. I don't really like this for PML, but I love the diagnosis of progressive multifocal leukoencephalopathy, so we can at least think about it. We could still potentially be dealing with lymphoma, though this is not a good appearance for infiltrating glioma, and toxic metabolic can probably be cast out, as those processes are typically symmetrical. But we still need more information, and in particular, we really want to see post-gadolinium imaging and diffusion-weighted imaging. So now we get those things. Here's our T1 post-GAD imaging, and we can see that these lesions are gadolinium enhancing, pretty much all of them to the same extent. When we look at our diffusion-weighted image and our ADC map, We see multiple areas of high signal intensity on the DWI, some of which do indeed restrict diffusion and are dark on the ADC, but some other lesions don't really restrict diffusion. And so we have a mixed picture. Sorry, I just lost my mouse for a minute. So with regard to our diagnostic considerations, what are our best fit? Well, certainly we're still going to like inflammatory demyelinating because the lesions are white matter, ovoid, perpendicular to the ventricular surface, periventricular in distribution. They are also perivenular. You can see the enhancing deep medullary veins, and we can see that these lesions have arrayed themselves along the venules, and they enhance. With regard to a vascular process, we still could potentially consider vasculitis, though we might be happier if more of these lesions had actual true restricted diffusion, and we could potentially consider the possibility of vascular or angiocentric lymphoma. Let me show a brief follow-up. These are the initial images from the patient. 1 week later, we can see that the patient has considerably progressed. Our MR thoughts remain reasonable, even though we now have this new piece of information. We could still be dealing with an inflammatory demyelinating process, or we could still potentially be dealing with vasculitis or angiocentric lymphoma, though I would like more DWI abnormality. So with that, let's return to the history. What we've seen is fine for altered mental status, fine to explain the potential for lymphocytic pleocytosis, which we can see with vasculitis or with demyelination. What about the cocaine? Well, there are 3 major types of cocaine-induced brain injury. Cocaine is associated with ischemic and hemorrhagic stroke through a mechanism of increased sympathetic tone, leading to vasospasm, acute hypertension. We could be dealing with cardioembolism or potentially a cocaine-induced vasculitis. We could be dealing with a metabolic cocaine-induced leukoencephalopathy related to mitochondrial dysfunction or hypoxic ischemic encephalopathy following arrest, or we could be dealing with an immune-mediated multifocal inflammatory leukoencephalopathy due to levamisole. So you're wondering, what is levamisole? This is an adulterant commonly found in cocaine. It is used for its anti-helminthic and immune-modulating properties, but it is associated with both an ANCA-positive vasculopathy and demyelination. It has been associated with acute to subacute brain injury in an imaging pattern consistent with demyelination. The CSF typically shows elevated protein and lymphocytes and monocytes, though it can be normal. This can improve with time. Steroids and plasmapheresis may help, but it also can recur if challenged with more cocaine. So if the patient did more cocaine during those 2 studies or between those 2 time points, that could account for the worsening. So my final diagnosis for case number 1 is levamisole-induced demyelinating leukoencephalopathy in a patient abusing adulterated cocaine. And yes, I do want to say that I get lots of my scientific information from the Daily Mail. Thank you.
Wow. These panelists are very clever. So the correct answer, levamisole-induced leukoencephalopathy, just as you explained. So levamisole is used as an antiparasitic agent as well as for other reasons. It's commonly used to cut cocaine. It's a white powder that actually also has some stimulant factors, so it fits in well and it's easy to use as a contaminant or adulterant in the cocaine. It's been used to treat diseases, rheumatoid, some cancer, but it's been taken off the market for use in 2000, although it still shows up in about 70% of cocaine samples which are got picked up by the police. It can cause multifocal leukoencephalopathy. There are other complications, and testing by urine assay can be done. So, fantastic. Okay, tough act to follow. Two people got the first cases right. Abdominal case number 1, John Leyendecker. So here's John. John is professor and vice chair at the University of Texas Southwestern Medical Center. He got his medical degree from the University of Pennsylvania. He did his residency in radiology at Emory University in Atlanta. He He did 2 fellowships, one in body MRI at WashU Mallinckrodt in St. Louis, and a vascular interventional radiology fellowship at Wilford Hall Medical Center. Before he went to UT Southwestern, he was at Wake Forest University, where I worked as well, and he was executive vice chair and professor at Wake Forest University. Okay, abdominal case number 1. 49-year-old male who presents to San Francisco General Hospital with altered mental status. John.
So, Ron, when I said I wanted a Euro radiology case.
I've always had that problem with Euro and Neuro. It's, they sound so similar.
But believe it or not, this was my first set of images, and it turns out actually to be fairly important and contributory to the final diagnosis. So those of you who are neuroradiologists in the audience, please forgive me, as I am truly an abdominal imager, but nonetheless, I'll do the best I can. So the first thing that I noticed was that there was a ring-enhancing lesion on this gadolinium-enhanced T1-weighted image, somewhere between the basal ganglia and the thalamus on the left, and in the region of the internal capsule. And you can see on the other images, the CT and other MR images, there's some surrounding edema associated with this lesion. But the curious thing is that the lesion is conspicuously inconspicuous. Somebody bent me that I couldn't say that up front here, but on the diffusion-weighted image. So I would have expected to see something there. So, as an abdominal imager, I have a fairly limited differential for a ring-enhancing lesion in the brain, and this is basically most of it. And I'm going to, right off the bat, exclude glioblastoma and demyelinating disease because that really wouldn't fit in well with an abdominal case. So we're left with lymphoma, metastasis and infection, and lymphoma in an immunocompromised individual is certainly a consideration. But I would hope to see more on the diffusion-weighted image, which I don't see here. In addition, metastatic disease could be a finding that you'd see with an abdominal primary, so it's a consideration, but again, I might expect to see that on DWI, and the same is true for a pyogenic abscess. So I don't like those as much, and I'm going to, right off the bat, look or favor some sort of atypical infection, including toxoplasmosis. Now, ultrasound was done a few days later, and I'm going to assume that the patient, when they presented with the neurologic symptoms, that they did not have any flank pain or renal insufficiency, and that this developed subsequent to their admission. Fortunately, this is fairly simple to sort out. We can see some echogenic foci within the kidneys surrounded by areas of low echogenicity. So these are basically stones within the urinary tract. And we can see some mild hydronephrosis, probably secondary to obstruction. Just to make the case more difficult, Ron turned the CT scans upside down, and we can see here multiple prone images demonstrating a dependent calculus in the bladder, as well as calculi within the distal ureter. There's one interesting thing about this, and they look a little bit amorphous, and in addition, they're not very dense. If you compare them to a phlebolith, you can see that they're not nearly as dense as the phlebolith. So these are some sort of atypical calculi. We see additional images in the coronal plane and some magged up view of the kidney or kidneys. And another curious thing about these stones is that they seem to be conforming to the ureter. So I'm guessing that they are not hard, densely calcified stones, as you again see the contrast with the pelvic phlebolith. The CT also seems to underestimate the stone volume that was seen on ultrasound. Again, they have this sort of faint, amorphous appearance, and you can see some signs of obstruction as well. Interestingly, 6 months later, they were completely gone, and there was no history provided of an intervention. So I'm going to assume that no intervention was performed. So I did what any sane person would do. I had two significant findings, urolithiasis and a ring-enhancing brain lesion. So I thought I would go to PubMed and see what the area of intersection was And this is a true screen capture. Unfortunately, this yielded absolutely no results. So then I did the next best thing. I went to Google, and this yielded 22,400 results. And actually, my children are still sorting through these for the correct answer. I forgot to tell them to stop. But the problem is none of these answers, or very few of them, actually had urolithiasis as a term. So I was actually going to have to figure this out on my own. So we have a 49-year-old man. There's a ring-enhancing brain lesion. Metastasis, lymphoma, or infection were on my list. I was favoring some sort of atypical infection. Kidney stones that come and go. And they're ill-defined and not particularly dense kidney stones. So my assumption here is that these stones were somewhat hastily formed or precipitated within the urinary tract. And that sort of the aha moment was when I thought maybe that these stones resulted from something used to treat the brain lesion and that they were not directly related. So I think what we're dealing with here is treatment-induced urolithiasis, and there's a couple ways that this could happen. One is a tumor lysis syndrome, and this can occur in, for example, the setting of lymphoma, which was on my list. Generally, what happens is you have cellular lysis, the cells release their contents into the bloodstream, and eventually things like uric acid, xanthine, and some calcium phosphate and other things will precipitate in the urinary tract and the renal tubules. But for this really to have a significant impact, you need a large volume of tumor, a large tumor burden. And these patients also tend to have a lot of metabolic derangements, which we don't see in our patient. So I'm going to exclude this from the consideration. So then we have medication-induced urolithiasis, and there's a variety of medications that have been shown to do this, which I would love to show you. There we go. And some of them are listed here. Acyclovir is one that can give you crystalluria, but it's used to treat herpes, and it's usually the intravenous form. It's used to treat herpes, but herpes tends not to involve the basal ganglia and thalami, and so I'm taking that off the list. Adinavir or other protease inhibitors might be a culprit here, but adinavir stones are known for their sort of invisibility on CT. They don't show up very well. And these stones, even though they weren't real dense, they did show up on CT. Methotrexate can give you a crystal nephropathy as well, but tends not to give you the disseminated urolithiasis we saw in this case. And so this leaves us with sulfadiazine, which is also used to treat toxoplasmosis, so it fits very well. It's the N-acetyl or N-acetyl sulfadiazine metabolite that tends to be poorly soluble in urine. It precipitates, usually in patients that are dehydrated, and it precipitates rapidly. It can occur in a few days, and it also resolves if you simply stop the medication, hydrate the patient, or alkalinize the urine. So I like that diagnosis of sulfadiazine-induced urolithiasis in a patient treated for CNS toxoplasmosis that he got. I'm going to go out on a limb here, but I'm going to say he actually had a pet cat. And this is my cat getting ready for RSNA.
Great work, John. It doesn't seem to matter whether it's uro or neuro. You did quite well on the ring-enhancing lesion. This was yours. So this was sulfadiazine. I think this may have been your slide, is a known complication of this therapy. High-dose urine acidity and dehydration are contributing factors. So here we go, stop. Correct diagnosis is, in fact, sulfadiazine-induced urolithiasis. For those of you in the audience who may someday be in a film panel, remember that often every word in the history, there's some meaning to it. So in the history, I said that this patient had been to San Francisco General Hospital, which is a well-known hospital part of the UCS system, but they did pioneering work in the treatment of HIV, very heroic work back in the early 90s and late 90s. And this patient presented there, was HIV positive, and was treated with sulfadiazine. It's interesting, now that hospital is called the Zuckerberg San Francisco General Hospital, thanks in part to a large grant from the Facebook mogul Steve Zuckerberg. Sulfadiazine is a sulfonamide-derived antibiotic. It's used for therapy of HIV-related CNS toxoplasmosis. The metabolite, as John mentioned, is poorly soluble and can precipitate, cause crystalluria, or overt stone disease. Some interesting features about this is, as John pointed out, these are not very dense. Obviously, these would be invisible on radiographic studies, but even on CT, these are much less dense than calcium stones, much less than the phlebolyths that he showed. They have a variable appearance on ultrasound. In this case, they looked like typical stones. They can be treated just with simple drug discontinuation or vigorous hydration. And this patient did have a cat. Okay, musculoskeletal case number 1, Christian Fearman. Here's Christian. So Christian is the chief of radiology at the Orthopedic University Hospital Balgrist, University of Zurich. He got his medical degree from the University of Zurich and Bern. His radiology training was at the Krankenhospital Luzern, and his musculoskeletal fellowship and some orthopedic surgery training was done at the Orthopedic University Hospital Balgrist. He did an MSK Radiology Research Fellowship at University of California, San Diego. For his case, the very limited history is a 57-year-old woman with short stature. Dr. Fearman.
Thank you very much. So the first images that I got were these bilateral humeruses. And the most striking finding is sclerosis. And if you look at the distribution, there is a predominance for the shaft. However, we see the sclerosis also at the ends of the bone and ribs and also the scapula. So sclerosis throughout. Here we have a radiograph of the pelvis. If you look at the pelvis, we see the coarse trabeculations with the thickening of the cortices and also expansion. If you look only here at this area, this resembles a Paget's disease. However, Paget's disease all over, that's very uncommon, could not be. Well, if you look at the femurs, we see the bone expansion again, and we see loss of differentiation of the medullary canal and the cortex. Here we have a CT of the pelvis, again the same findings, diffuse sclerosis, coarse trabeculations in the ilium. And the central part, in the sacrum and the spine, we see thickening of the cortex and rarefication of the central areas. There is almost no bone visible here. Here we have an MR of the spine. We have normal segmentation, and important for a differential diagnosis, the spinal canal seems to be normal. However, if you look at the bone marrow, it is hypointense in nature on all sequences. Reason for that could be sclerosis. However, we have seen on the CT, we have even rarefication of the trabeculae. So it could be fibrosis, and fibrosis would be a metaplasia of the bone marrow. Now we have here a CT of the chest. This is clearly to bring the bone radiologist out of the comfort zone, and I have a simple rule for that. Either it's still the bone, or it is a very simple finding that the bone radiologist can see. Well, we have discussed already the bone changes, the sclerotic changes which are evident here as well, of course. But I go with a simple finding, which is an enlarged heart, some effusions, and some consolidations in the lung. So summarizing the findings, all bones are affected. We have expanded bones, which also goes by osteoectasia. We have these findings similar to a Paget's. We have loss of definition between the cortex and the medullary bone. We have a diaphyseal predominance, but also the epiphyses are affected. In the spinal thorax, we have deformation and remodeling. Again, the Paget-like appearance. We have osteoblastic, metaplastic, and fibrous changes, and we have the cardiomegaly. So we're dealing here with some kind of malfunctioning of the bone remodeling. And this brings us to the large area of the sclerotic bone dysplasia. In analyzing those, usually lab studies addressing the bone metabolism or even genetic studies are usually used to make the differential diagnosis. However, going only with the imaging findings, here is the list of the possible differential diagnoses. First, diaphyseal dysplasia, also called Camurati-Engelmann's disease type 2. This disease usually affects mostly the diaphysis and not the epiphysis, so we take that off. Then hyperostosis corticalis generalizata, or Van Buchen's disease. This disease is usually characterized by endosteal hyperostosis, and we also take this from our list. The next one would be hyperostosis generalizata with striations. The appearance of the long bones would be quite well. However, we don't have the typical striations which are present usually in the spine, and these patients are usually normal in height. Then we have hereditary hyperphosphatasia, or also called juvenile Paget's disease, and this is probably the best fit. We have this typical Paget-like appearance. And the last differential is hyperphosphatasia with osteoectasia. Again, this would fit very well with the bony appearance, the long bones. However, these patients are usually tall, even morphonoid. So I will go with my final diagnosis, hereditary hyperphosphatasia or juvenile Paget's disease.
Excellent. Great discussion. So the correct diagnosis is hereditary hypophosphatasia, just as you had suggested. A lot of these odd diseases have numerous synonyms. So as you mentioned, the last one, juvenile Paget's disease, but there are also other names that are used for this. But the most current is hereditary hypophosphatasia. This is a genetic disorder. It's autosomal recessive, but there can be spontaneous mutations. It causes increased bone turnover. It does manifest during early childhood, but it progressively leads to more malformations due to the abnormally soft bones resulting in short stature, which was the given history in this patient. The main imaging findings are the increased diameter and density of the long bones, thickened cortices, coarse trabecular pattern, all of which you pointed out, the enlarged vertebral diameter with decreased height and increased density. Boning remodeling and deformity are throughout the skeleton, and for some odd reason, these patients typically get cardiomegaly, as was shown in this case. Beautiful, great discussion. Okay, next case. Our first of the chest cases, Gautam Reddy. Gautam is shown here with some of his textbooks that he's authored. Again, these are all very established, renowned radiologists. Gautam got his bachelor's degree from Harvard, his medical degree and master's of public health from GW University in Washington, D.C., did his residency at Thomas Jefferson University, then a fellowship in cardiac and thoracic imaging at UCSF. He was a section chief there in cardiac and pulmonary imaging and the program director of the residency program. He currently is the professor and vice chair for education at the University of Washington. He has had an esteemed career. He's a young man, but has done very much during his career. He's been the president of North American Society of Cardiovascular Imaging, other high offices that he's held, including deputy editor of 2 of the major journals. He was an RSNA research scholar and honored educator. So for chest case number 1, the only history you get is a 57-year-old female, but I think the findings are not very subtle.
So thank you. And since everyone got their cases right, I feel no pressure at all. So this patient has, first of all, on the radiograph, what we see is this upward retraction of the hyla. So that suggests that there may be fibrosis. And if we look peripherally, we can see these opacities suggesting fibrosis. It's not absolutely clear, but that's the strong suggestion there. So I would say this is likely fibrosis. Then we have a radiograph 3 years later, and notice that there's more fibrosis. It's become more extensive, but it's starting to go in from the periphery. So we see quite a bit. On the follow-up radiograph, so this is 5 years from the baseline, we see progression, and it's going further in, progressing from the periphery on the initial scan inwards, and it goes from outward in. I think that's a critical finding. So again, just to look in quick succession, notice where the fibrosis is. It's at the periphery initially, starting to go a little bit more in and become more extensive, and then it still is peripherally predominant, but involves the more central part. So then with the CT scan, this is 5 years after the initial radiograph. We can see in the apices that there is reticulation and architectural distortion, which are two findings seen in fibrosis. We also see traction bronchiectasis, again, also an indicator of fibrosis. So clearly the patient has fibrosis. Notice that the upper lobes are worse than the bases, which there is some involvement here, but it's relatively mild. And one other thing that we need to look for when we identify fibrosis is honeycombing. Does the patient have honeycombing or not? And honeycombing is lung destruction, so we look for pure black holes indicating air. And they are in the periphery and typically more than one layer away from the pleura. So there's one location I would suggest. We can see 2 layers here, another here. I'm not sure about this, but it may be, and then also possibly this. And down here in the right middle lobe, we can see these areas here. So there is honeycombing here. It's relatively mild, but I would venture that there is honeycombing. And the coronal view does show that there's superior upper lung predominance and peripheral predominance. There's superior retraction of the hyla. There's architectural distortion and reticulation, as well as traction bronchiectasis. So there's upper lobe predominant peripheral fibrosis. So to summarize the findings on the radiograph, reticulation with peripheral and upper lobe predominance, hilar retraction, and outward to inward progression over the 5 years. And on CT, fibrosis with peripheral and upper lobe predominance, honeycombing, and there are no cysts or nodules, no cystic lung disease, no nodules. So the differential diagnosis for peripheral fibrosis, usual interstitial pneumonia, or UIP, which can be related to idiopathic pulmonary fibrosis, asbestosis, drug-related fibrosis can cause a UIP pattern. Non-specific interstitial pneumonia and pleural parenchymal fibroelastosis. These are some of the possibilities. I'll go through these. So usual interstitial pneumonia tends to be progressive and causes honeycombing, as we see in this case. So that's consistent with this particular patient's findings. But UIP is usually lower lobe predominant, which is inconsistent. Non-specific interstitial pneumonia, typically seen in collagen vascular disease such as scleroderma or rheumatoid arthritis, has findings that are relatively stable or only slowly progressive, no honeycombing usually, typically lower lobe predominant, and subpleural sparing. And none of those findings fit with this particular patient. And pleural parenchymal fibroelastosis tends to be progressive. There is honeycombing, there's upper lobe predominance and inward progression. It starts in the periphery and then starts to involve the more central aspect of the lung. So that's for peripheral fibrosis. How about upper lobe fibrosis? So this is by no means an exhaustive list. There are quite a few entities that I'm not going to discuss. But these are some of the considerations. Sarcoidosis, drug-related fibrosis, which can have a UIP pattern with lower lobe predominance and peripheral predominance, or it can have variable predominance. Chronic hypersensitivity pneumonitis, and again, we see pleural parenchymal fibroelastosis. I put RAS, which is restrictive allograft syndrome seen in lung transplant patients, but since this patient hasn't had a lung transplant, there's no history or evidence on the images, we won't consider that. So, and RAS can be thought of as in the spectrum of pleural parenchymal fibroelastosis. So sarcoid can be progressive and it causes honeycombing, as in this patient, but typically the distribution is more central, upper lobe central. We can see nodules, especially in the perilymphatic distribution, and in the end stage we can see conglomerate masses mimicking silicosis. Chronic hypersensitivity pneumonitis tends to have a mid-lung distribution, but it can be upper lobe predominant. There's relative sparing of the costophrenic sulcus. So those could be consistent with this patient's findings, but typically there will be ground glass opacity, mosaic perfusion, or air trapping, and the head cheese sign, which is a combination of mosaic perfusion and ground glass opacity. We don't see any of those findings. And drug-related fibrosis, as I mentioned, can have a variable distribution, including upper lobe predominance can have honeycombing. But the progression tends to be less severe and less likely after the initial exposure. And the progression tends not to be inward, from outward to inward. And I said pleuroparenchymal fibroelastosis fits with all of the findings in this patient. So I would favor that diagnosis, pleuroparenchymal fibroelastosis.
Very logical. Okay. And the correct diagnosis is pleuroparenchymal fibroelastosis. So this is actually a histopathologic pattern of injury, something found by histology with a radiologic analog to that, which was shown here. It's upper lobe predominant fibrosis and deposition of elastic fibers. Causes fibrosis of the visceral pleura. It's nearly identical histologically to the very ubiquitous apical fibrous cap, which we see, but obviously this is much more severe and eventually can involve the entirety of the lungs. But it's thought to possibly be due to an ischemic etiology similar to that seen for apical fibrous cap. This is fibrosis and honeycombing are the main findings. It's apical subpleural distribution, as was described, progressive nature, pleural thickening. Its etiology, it can be many causes, but the majority of these are idiopathic, can be seen with bone marrow transplant, stem cell transplant, lung transplant, rejection, drugs, and chronic infections. It accounts for up to 6% of interstitial lung disease in one particular study, so it's not at all that rare, although I have to admit I'd never heard of this. The mean age for patients is in their 50s. And the mortality can be as high as 50% in the follow-up period, which ranged from 4 months to 2 years in one study of these patients. So fantastic work. Okay, round one. You all were absolutely wonderfully clever and figured all these cases out, and again, lived up to the billing as experts in the field. So without further ado, we're going to move on to the second round. We'll have 2 cases. This is the second case for each person. Okay, Dr. Chung. And at this point, I wanted to also emphasize these people obviously are extremely talented radiologists, but they do have lives outside of radiology. So I asked them to send me some candid photos. Here's Ellen skiing. This looks like perhaps Davos, I'm not sure, but in a skiing group, and you fit right in there. Although one of the things about skiing is you can never tell who anybody is in any of those pictures, but I'm assuming you're one of these people up front there. And Ellen says she's better at dancing than skiing, which you can also do there. Looks like a wonderful ski resort. So again, well-rounded people. Second case, pediatric case number 2, a 7-year-old male with arm pain. Sorry.
Yes, so that was the last time I skied, and that was 2004, because I fell.
And this is not your arm. This is
on the bunny slope. All right, so this radiograph demonstrates a pathologic fracture. We can also see that there is a lucent lesion, which is mildly expansile, involving the metadiaphysis of the proximal humerus. This image shows that there are some septations within it, but also the appearance of possibly a fallen fragment sign, which is very useful. The cortex is a little bit expanded, but it's not that thin. We can clearly see the cortex is still present and not disrupted except where there's the fracture. So our findings so far, expansile lytic lesion in the proximal humeral metadiaphysis or metaphysis with some septations, a pathologic fracture, and possibly a fallen fragment sign. So really this looks like a solitary bone cyst, but for the purposes of this exercise, I included more things in the differential diagnosis that could also be considered. It really doesn't have the ground glass appearance of fibrous dysplasia, but I'm still going to leave that one there. Non-ossifying fibroma should be an eccentric lesion, which this is not, so we'll probably take that one off. Longer on cell histiocytosis we may still consider. Aneurysmal bone cyst should be eccentric and have a markedly thin cortex and almost imperceptible, and so we don't have that finding. So I'm taking that off as well. Telangiectatic osteosarcoma, unlikely, but I'll leave it there. Other rarer things would be like a brown cyst, a brown tumor of hyperparathyroidism, but that would be quite unlikely. So this is what I'm left with so far, although really it looks like a solitary bone cyst. So then an MR was provided. The yellow arrow indicates an area of fluid signal intensity on this T2 weighted image. And then the red arrow shows an area that has a lower signal intensity, more lateral and inferior. Within the fluid signal intensity portion, there is a fluid level, as shown by the blue arrow. You can see it with enhancement that there is peripheral rim enhancement of most of the lesion. But if we compare the axial or the coronal T1 weighted image on your left to the post-gadolinium coronal T1 weighted image on your right, you can see that there is a difference in the amount of enhancement. So the yellow area is showing the fluid signal intensity portion on the T2 weighted image. It does not enhance except at its periphery. But then the other portion, which also is hypointense on the MR, on the T1, which was also darker on the T2, enhances quite a bit. And that was adjacent to the area where we saw the fracture. So now we have a proximal component that's cystic and has a fluid level in it, and then the distal lateral component is hypointense on both sequences and enhances fairly intensely. So because there is a cystic component, we're going to take out fibrous dysplasia and Langerhans cell histiocytosis, and that leaves us with these two. The solitary bone cyst, you would not expect to have a lot of enhancement, but once there's a pathologic fracture, it can look very complex, and there's also hemorrhage as manifest by the fluid level. So I think that that could be the appearance of a solitary bone cyst with reactive change due to a pathologic fracture. Telangiectatic osteosarcoma is much less likely. It's rarer and should be more complex in appearance. And the plain film appearance really looks like a solitary bone cyst. So I'm going to go out on a limb and say solitary bone cyst with hemorrhage and reactive change due to fracture.
Thank you very much. So this came from our pediatric radiologist, John McKenzie, and the correct diagnosis is a bone cyst with a healing fracture. The key thing here was that there was that very avid enhancement at the periphery of this healing fracture, which to my eye looked very worrisome for neoplasm, but this is in fact just due to remodeling and fibrosis, a normal part of the healing process. And the key is not to mistake this for an osteosarcoma, which would be relatively easy to do because of some overlap of findings, but not for you. Good job. Thank you. Okay, neuroradiology case number 2, Nancy Fishbein. And here we see Nancy with a beautiful family, her husband, who I think is also a physician, and her children, and we can see them at the beach, the bottom picture there. And again, these are very well-rounded people. Okay, neuroradiology case number 2, a 46-year-old woman with refractory seizures, right hemiparesis since early childhood, recent declining vision, mild hematuria on screening urinalysis, and a family history of early strokes.
Okay.
So another uro-neuro case.
Yep, right. Oh, yeah, right, definitely. Oh, Euro-Neuro, perfect. That's our theme for the year. Okay, so as usual, I do like to start by dissecting the history, and any resident or fellow who's ever been in the reading room with me knows that I'm kind of crazy about this. So here we go. So this is a 46-year-old with refractory seizures and right hemiparesis since early childhood. So right off the bat, we're kind of wondering which came first. You know, are we dealing with a stroke with secondary seizure, or are we potentially dealing with seizure-induced injury from perhaps status epilepticus and repeated seizures? And so we're wondering, are we going to see some kind of brain injury or potentially, a scary thought, a brain malformation? We also know that the patient has recent declining vision and mild hematuria on a screening urinalysis. So vision and kidney problems definitely make us think about small vessel pathology with retinal and glomerular injury. In addition, because this is recent and now she's 46 and this other stuff started in early childhood, we know that there is a progressive component to this problem, and so we're not just going to be dealing with some static situation or brain malformation. And then finally, we have a family history of early strokes, and so we definitely want to be thinking about the possibility of genetic or metabolic disorders. So now let's take a look at the imaging. And I have to say that when I first looked at this, I really did have one of those, oh my God, moments of panic until I started, breaking it down. So what are the findings in this case? First of all, on the upper row, we have 2 flare images. And on the flare images, we can see that there is diffuse, although somewhat asymmetrical, white matter hyperintensity. So we have a diffuse abnormality of signal of the white matter of the cerebral hemispheres. We also can appreciate that we have several holes in the white matter on the right side and potentially a hole on the left side, although just on these images, I wasn't sure if I was just looking at the upper aspect of a dilated atrium. We do certainly have ex vacuo enlargement of the left lateral ventricle, and in the areas where the white matter signal is not abnormal, we have white matter volume loss, and we can see how the bottom of the sulcus and the gray matter there is practically opposed to the ventricular surface. On the lower row, we have gradient echo images, and we see that there are innumerable foci of GRE susceptibility, right more than left. These are probably microhemorrhages and foci of hemosiderin rather than calcium, just because of the degree of magnetic susceptibility. It's hard to be absolutely sure without a CT scan or some other, more advanced MR imaging, but for the moment, we will just assume that we have diffusely abnormal white matter with holes in it and multiple areas of microhemorrhage. So at this point, we are in a little bit of a panic, but we still have some more images to go through. So I was also given a time of flight MRA image. Here we have a lateral view of one of the carotids. These are the anterior cerebral arteries, posterior communicating artery, and PCAs. Now we're not seeing an MCA, so we may be dealing with occlusion of an MCA and large vessel pathology, but it's also possible that it was simply excluded from the volume of the images. One thing we can say, however, is that there clearly are one or more aneurysms on the MRA. We can see here as well as here. Again, it's a little hard to be sure whether we might be dealing with the top of the basilar, but given that we only have one view from the MRA and we don't know what was excluded, we'll just accept the fact that we have at least one aneurysm. We were also given diffusion-weighted imaging and ADC map. There is no diffusion restriction. Similarly, there is no post-gadolinium enhancement on the post-GAD image. So with regard to my thought process at this point, there's no brain malformation, there's no evidence for tumor or inflammation. A vascular etiology seems reasonable by history and imaging. We have a pattern that's not inconsistent with small vessel disease affecting the white matter. We have multiple microhemorrhages, and we have aneurysm formation. So the question is, what are we going to do with this? So at this point, I took a little detour, and I started thinking about stroke in the young, and especially in a patient with a positive family history. And we want to consider single gene disorders that are associated with strokes. This would include the possibility of CADASIL, which stands for cerebral autosomal dominant, arteriopathy with subcortical infarcts, and leukoencephalopathy and its relatives. And we're going to talk more about this in a minute. We could think about Ehlers-Danlos, which certainly is associated with strokes, but often through a mechanism of vascular dissection. And we weren't given any evidence of dissection. Nobody told us about hyperextensible joints or that sort of thing. We could think about Fabry disease as well, which is a cause of early strokes. But in Fabry disease, there is a characteristic MR finding, which is T1 hyperintensity in the pulvinar of the thalamus, and that was not present here. And Fabry's is a lysosomal storage disorder. We could also think about the possibility of homocystinuria, which is a disorder of methionine metabolism, but these patients often have a Marfanoid body habitus. We were not given that history. And similarly, Marfan syndrome, again, no history of a Marfanoid body habitus. We've got the onset in infancy, early childhood. It's not a very good fit. And similarly, sickle cell disease, we don't have a history of the patient being African American. Additionally, we are dealing more with a small vessel process based on the white matter than a large vessel process that we might expect, say, with Ehlers-Danlos or Marfan's. So just to digress for a minute into CADASIL, this is a non-atherosclerotic, non-amyloid microangiopathy that has a characteristic progression from leukoariosis and microhemorrhages to recurrent strokes, and this is caused by an autosomal dominant mutation in the Notch3 gene. These patients have cognitive dysfunction, migraine headaches, psychiatric symptoms, recurrent strokes, as I mentioned. The eyes and kidneys can be affected, but aneurysms are rare, and the onset is typically in an older age group. Pathologically, there's deposition of a granular osmophilic material that leads to degeneration of vascular smooth muscle cells. But we don't really like CADASIL for the reasons I just mentioned. Another consideration would be hereditary endotheliopathy with retinopathy, nephropathy, and stroke, also known as retinal vasculopathy with cerebral leukodystrophy. This is caused by a mutation in the TREX1 gene. Again, it's not a bad fit clinically, but we don't specifically get the history of aneurysms, and this is usually an adult onset situation. Another thing to consider would be a COL4A1 related disorder. The COL4A1 gene on chromosome 13 directs synthesis of a component of type 4 collagen. This is important in basement membrane networks. And when we have a problem with COL4A1, we may have a situation of autosomal dominant familial porencephaly, autosomal dominant brain small vessel disease with hemorrhage, or hereditary angiopathy with nephropathy, aneurysms, and muscle cramps. These disorders are multi-system, affecting brain, eye, kidney, and potentially muscle. So my differential at this point was CADASIL versus COL4A1 related disorder versus Hearn's or some other designer genetic defect leading to early onset arteriopathy with cavitating leukoencephalopathy. My final diagnosis, or my best fit diagnosis, I should say in this case, was COL4A1 related disorder, specifically autosomal dominant brain small vessel disease with hemorrhage. And if you go to the OMIM, it is number 607-595, and my kids can sort more quickly than John's kids.
Well, great analysis of this case. Again, these were all very, very tough cases. Some I thought were absolutely impossible, but this was possible. As Chris said, you are a rock star, all of you. COL4A1 mutation. This is a gene encoding type 4 collagen abnormality, the major component of vascular basement membrane. So all of the basement membranes in the body are involved. It's inherited with an autosomal dominant pattern with some sporadic cases. It is multi-system disease, again, because it involves basement membranes in the brain, leukoencephalopathy, deep hemorrhage, calcification, lacunar infarcts, porencephaly. And the diagnosis is made by genetic testing, which was done in this case to confirm this diagnosis. We had to hold off sending this until we had the confirmation of the genetic testing, but it was in fact the diagnosis. Great work. Okay, abdominal case number 2, John Leyendecker. So here's a cute John when he was a child, a little bit older, still a handsome guy. And here's his beautiful family. Mary's here in the audience, and his children Michael and Bridget. Their children. And John's hobby is astronomical photography, so he likes to go far out into the wilderness and dark places and take photographs, which occasionally I'll see on the internet and Facebook. And once at least I've seen him go fishing, and here's a fish which he said was only about 2 inches long, but he's got long arms, so it makes it look much longer. So abdominal case number 2 for John. 50-year-old female with abnormal liver function tests.
So obviously I've undergone some sort of malignant transformation since I was a child. But anyway, so the key to this case, I believe, turns out to be the anatomy. So I'm going to spend some time going through a series of CT images of the abdomen to identify and clarify the anatomy in this case. So this is the IVC. I think everybody sees that. By the way, I understood 2 words of your presentation. Kidney and nephropathy. And the rest, I have no idea what you were saying. So that's the IVC. And we have here also a liver lesion, and you'll see more of those as we go along. And here again is the inferior vena cava, which is in the normal location, but there's this odd other vessel here centrally within the liver that really doesn't belong in that location. We also see additional liver lesions. Further down, we can see again the IVC, then we see this mystery vessel. We also see a large, somewhat heterogeneously enhancing mass in the left upper quadrant. It has, presumably, as you'll see later, this is confirmed, areas of intense enhancement and areas that are less enhancing that are presumed to be necrosis or hemorrhage. A little farther down, we can see the liver and spleen as separate organs, and so this mass is clearly coming from the liver. In addition, we see the IVC, and now we can say that this mystery vessel, which is, appears to go down to this location, is located right behind the pancreas, exactly where the portal confluence should be. I think also we see a little bit of the splenic vein coming in there, but it's a little hard to tell in the images I have. On a 5-minute delay, this confirms that that was truly enhancement and not calcification, and those areas that were hypoattenuating on the prior image remain hypoattenuating, so that's consistent with hemorrhage or necrosis. The sagittal images were provided, I believe, to clarify the anatomy farther. You might confuse this with the IVC because it does drain into the hepatic confluence in the heart. However, we can see here's the aorta. We should never see the IVC and the aorta on the same slice of a sagittal image. We see the SMA here, and the IVC obviously does not belong anterior to the SMA, and that might be the SMV draining into it. So this is probably not the IVC, and in fact, we can see the IVC separately on the coronal in its normal location. One thing that is hardest to see is that which isn't there, and in this case, it took me a while to realize that there was no normal intrahepatic portal vein, this is conspicuously absent in this case, and it appears then that the portal circulation is draining directly into the IVC. So putting it all together, we have a 50-year-old woman. This really isn't necessary, but I spent a lot of time on these little illustrations here. There's a portosystemic communication, and the 2 choices are it's either congenital or acquired. Now, there's no evidence of portal hypertension. The patient has no evidence of prior surgery. There's no evidence of a normal portal vein, intrahepatically at least, and so I'm going to exclude the possibility that this was acquired and go with a congenital abnormality. There's a large, sort of ugly-looking, enhancing liver lesion and additional liver lesions throughout the remaining liver. So what we really have here is a portosystemic shunt associated with a congenital absence of the intrahepatic portal vein and presumably subsequent development of liver tumors. And I have to say, in a 20-year career, over 20 years, I've only diagnosed this twice in my life, so it's quite rare, and it's something that goes, I believe, by the name of Abernethy syndrome or malformation. And this is a rare congenital anomaly with portosystemic shunting, and it's divided into 2 types. The first type, or type 1, is associated with absence of the portal vein, which I believe is the case here. It also has a female predominance and can be associated with abnormal LFTs. Also can be associated with congenital anomalies like polysplenia, abnormalities of situs, cardiac abnormalities, encephalopathy, and hepatopulmonary syndrome, which I don't believe were present in this case, or at least I don't have that history. There's 2 types. One involves separate drainage of the splenic and mesenteric veins, and the other is a common trunk. I think I didn't see an anomalous splenic vein, so I'm going to go in this case with a common trunk. There's also type 2, which has a hypoplastic portal vein, but I think this is probably a type 1B. Now, that's fine for the vascular anomaly, but what we didn't talk about are the liver lesions. Well, it turns out Abernethy malformation is associated with a variety of hepatocellular type lesions, This is the sort of the list here, all originating from the primarily from the liver. I'm going to get rid of hepatoblastoma right away because that tends to be a pediatric tumor. It does occur in adults, but it's extremely rare. You know, it's difficult to distinguish from HCC and other tumors, but I think given that we're dealing with a 50-year-old woman, we could probably exclude that. Nodular regenerative hyperplasia tends to look like liver. I'm not sure if we saw any of this in this case, if any of those nodules consisted of regenerative nodules, but nonetheless, it really should look more like liver than that big ugly tumor. And really what I'm focusing on now is this large hypervascular mass in the left upper quadrant. I don't think that's a focal nodular hyperplasia. Those are usually more organized. They're typically not associated with hemorrhage. They have a central scar, usually if they're large, or at least a lot of them do. They have radiating septa. They're fairly organized and predictable in appearance. They don't have this irregular, disorganized appearance, and they don't have typically hemorrhage or necrosis. Now, it gets a little more difficult because distinguishing hepatic adenoma from hepatocellular carcinoma is not always possible. Adenomas, as you know, can hemorrhage. They do occur in Abernethy malformation. They can occur in large numbers in this abnormality. So I exclude this with a little hesitation, and the only reason I exclude it is because this mass is very vascular, very heterogeneous in appearance, and on one of the other images I didn't show was an arterial phase. You could actually see some abnormal tumor vessels going to this area of the liver. So I'm going to favor this to be hepatocellular carcinoma, and here's an example of an adenoma, typical adenoma without hemorrhage. It's usually a little less ominous appearing. So we're going to exclude adenoma and go with hepatocellular carcinoma as most likely. So my final diagnosis would be a type 1B, probably 1B, Abernethy malformation with hepatocellular carcinoma, and a bunch of other liver things which probably are a combination of adenomas and regenerative nodular hyperplasia.
Okay. Great work, and the correct diagnosis is congenital portosystemic shunt with hepatocellular carcinoma, also known as Abernethy malformation. Yay. Fantastic. So that this person did not have cirrhosis. That tumor was atypical, did not have classic features of anything, and we thought it could possibly be an adenoma or HCC, but we biopsied that mass and it was in fact proven to be hepatocellular carcinoma with this vascular malformation. These patients can get hepatocellular carcinoma and multiple other benign regenerative nodules, and they can get adenomas. This was first described, this anomaly, in 1793 by John Abernethy, who was a surgeon. The shunt causes ischemia, and that results in abnormal hepatic growth factors and hormones that results in the growth of these numerous masses. And it can often be associated with other congenital abnormalities, but not in this case. About 50% of these patients develop liver masses. They're mostly benign, although they can occasionally get hepatocellular carcinoma, and hepatoblastomas can develop, and a proven HCC was shown in this case. So beautiful description of this case, and again, very difficult cases. Okay, next to last case, musculoskeletal case number 2, Christian Fearman. So I hope this won't be too scary, but Christian's a very athletic looking guy, but he's not a serial killer. He actually likes to cook, which apparently his wife likes, except that there's a lot of cleanup afterwards. So he's here showing off his prowess in the kitchen and asking for a kiss. And here's his beautiful family on holiday, and they're shown here with their Swiss t-shirts. Very pretty family. Okay, musculoskeletal case number 2, 18-year-old man with stiffness. That's perhaps an understatement.
So we have radiographs of the feet bilaterally, and the striking finding here are deformed first toes. The proximal phalanx is short and fused with the distal phalanx, very symmetric. We have hallux valgus. We have a deformity of the head of the first metatarsal head. So because this is very symmetric and it's in a fairly young person, it's presumably congenital. Then we have bilateral films of the hands, and the finding here are short metacarpal bones, the first metacarpal bones, are shorter than normal. The other bones seem quite normal, no evidence of inflammation, which could be a reason for stiffness. The joints seem normal. Then I got an MRI of the spine, axial T1 with GAD, and a T2. And I had a history. Patient had a biopsy of the right kidney when he was a young child. Now this raises the question, what's wrong with the kidney and why was there a biopsy? Well, I can't find a lot on this kidney. Seems fairly normal to me, so I have to go back to my rule. It's either an easy finding or it's still the bone. Well, when we look at the bone, the spine looks fairly normal. But when we look here close to the kidney, this could be bone as well, because we have here cortical bone and in the center some medullary bone with fat. But this bone is in wrong location. This could be heterotopic bone. And one reason for heterotopic bone here could be the biopsy. The biopsy could have led to the heterotopic bone, and this could be a clue to the diagnosis. Indeed, when you look at this scoliosis film, which only shows a mild scoliosis, if we look here far down, we can appreciate that there is indeed a little bit of heterotopic bone, and it's really at the wrong location. Then I have an MRI of the pelvis, which shows fusion of the SI joints on both sides. Usually when you have a fusion in the joint area, this is post-inflammatory. However, on the image on the left, there is no evidence of inflammatory disease. There is no bone marrow changes, no bone marrow edema. So this is probably another reason. Summarizing the findings, we have symmetric malformed great toes, hypoplastic proximal phalanx with hallux valgus. We have symmetric short first metacarpal bones. We have this soft tissue ossification, and we have fusion of the SI joints. My differential diagnosis is really based on the malformed great toes, which are symmetric and probably congenital, and therefore the list is quite short. First on the list is fibrodysplasia ossificans progressiva. Second, isolated congenital malformation. And third, brachydactyly or Morton's toe. The two lower ones are not associated with other findings. Fibrodysplasia ossificans progressiva is really associated with the deformed first toes. And this is the hallmark of a newborn child with this disease, and pediatricians know this. This disease is very rare. However, it is very important to recognize this very early, because these patients suffer from ossifications which can be caused by minor trauma or by surgical treatments or even a biopsy. So this really fits to the diagnosis: malformed great toes, these heterotopic ossification, and also the fusion of the SI joint fit well with the fibrodysplasia ossificans progressiva, or FOP.
Well, fantastic, and it is a very rare diagnosis, but it turns out at UCSF there's a specialist who's doing numerous clinical trials in the treatment of this disease, fibrodysplasia ossificans progressiva, so we have seen a number of cases. Brilliant. This is also known as Stoneman syndrome, and you can see all of this heterotopic bone which can form and be very deforming as the patient ages. A very debilitating, crippling disease, and again, they're in search of a treatment for this, and there are some clinical trials ongoing. The prevalence, it is very rare, 1 in 2 million live births. It's characteristic hallmark is malformations of the great toe, as were shown, but they also get these progressive heterotopic ossifications, often in areas of minor trauma or spontaneously as there's unrecognized inflammation. Flare-ups occur spontaneously, and they can be misdiagnosed as soft tissue tumors because of the mass effect. These patients should avoid soft tissue trauma, like that biopsy. Of course, they didn't know that at the time that the patient had this diagnosis, but they can form these large heterotopic bone formations in area of even minor trauma. It is an autosomal dominant disorder of bone, a heterozygous mutation of a bone morphogenetic protein type 1 receptor. Developmental skeletal defects and extensive heterotopic ossification occur during childhood. So great work. I want to emphasize these experts figured out all of these cases. I did not tell a single diagnosis to any of these. This is just amazing how clever everyone is. So Gautam, the pressure's on. Chest case number 2. So here's Gautam with his lovely family shown here. It looks like you have 2 children. And case number 2, 21-year-old female. Let's go ahead.
Okay, so the radiographs show large lung volumes, and you can see lucent areas bilaterally, especially involving almost the entire right lung and much of the left lung, especially the upper, or at least the upper left hemithorax. And in the lower aspect of the chest, we can see more opacity, suggesting atelectasis. So this is either emphysema or less likely cystic lung disease. Now, the CT scan actually shows that the right lung has herniated over, and all of that lucent area is actually only in the right lung. It's unilateral. So it wasn't bilateral disease, it's unilateral. It's still most likely emphysema. This is quite a bit of lung destruction and appears to have this has the appearance of emphysema. That's the right upper lobe, and the left lower lobe is relatively spared. But as we see here on a slightly lower image, the left upper lobe appears to be mainly collapsed, largely collapsed, as does the right middle lobe and probably the right lower lobe. The coronal CT shows this hugely expanded right upper lobe. The right middle and lower lobe is here, it's collapsed. The left upper lobe is also collapsed. The left lower lobe is relatively normal. Look at the airway. You can see the trachea, the right and left main bronchi, and the right upper lobe, the bronchus intermedius here. They all look normal. So the findings on the radiographs, we see lucency of the right hemithorax and the upper left hemithorax, which turns out to be all the right lung. Emphysema or less likely cystic lung disease. There's opacity at the bases consistent with atelectasis, and that's probably compressive atelectasis because the rest of the lung expanded. That right upper lobe expanded. The CT shows marked lucency in the right upper lobe, likely emphysema. There's herniation of the right lung across the midline and collapse of some of the lung and normal airways. So the differential diagnosis, my first pass through the differential includes congenital lobar overinflation, a 21-year-old, but this congenital disease can occur in young adults, can be seen in young adults. Panlobular emphysema, Swyer-James syndrome, and vanishing lung syndrome. So in congenital lobar overinflation, most of these patients have involvement of the left upper lobe, but this patient had right upper lobe, which occurs in about 20% of individuals. There tends to be overinflation as opposed to emphysema per se, so that doesn't fit. Also, this usually presents in childhood, although occasionally it occurs in young adults. And the thorax may be asymmetric in adults because of the developmental abnormality. So panlobular emphysema, such as from alpha-1 antitrypsin deficiency or methylphenidate Ritalin lung, results in severe emphysema. However, the distribution is most typically in the lower lobes, and this unilateral right upper lobe involvement is atypical. And it also will be bilateral. Swyer-James syndrome, which is a post-infection obliterative bronchiolitis, tends to be unilateral, as in this patient, but the hyperlucency and air trapping occur in a relatively small lung. So the hyperlucent lung is relatively small. It doesn't expand like this. And in vanishing lung syndrome or idiopathic giant bullous emphysema can be unilateral or bilateral. The upper lobes are most frequently involved. It occupies at least 1/3 of the hemithorax. but there should typically be a trampoline sign, meaning peripheral emphysema, and this image on the top is from a different patient published in the New England Journal of Medicine, and you can see this peripheral lucency, and this is known as the trampoline sign, in which this is the part of the canvas part of the trampoline in which someone can jump, and this is the edge composed of free space. But whereas our patient doesn't have that finding. So coming back to the images, there are a couple of other findings. I remember when I was in medical school, I was told to always look at bones and soft tissues first. I never do that. I look, but that's not the first thing I do. I start with the lungs, which is right in the middle. That's easiest. I start with the heart and the lungs. But coming back to the soft tissues, look at the axillary fold there. It's compared to the more normal left side. Also look at the breast. The right breast is asymmetrically enlarged here, and I think that may be part of the right breast as well. Whereas the left breast is more normal. So there's soft tissue enlargement on the right side. It's unilateral, and that's also the same side as the emphysema. So I added these to the differential neurofibromatosis type 1 and Proteus syndrome. So NF1 can present with emphysema or cysts in the lung. Patients get soft tissue abnormalities, especially neurofibromas. They can present with ribbon deformities of the ribs, which we don't see here. We don't see vertebral abnormalities, no kyphoscoliosis, no hemihypertrophy or dysplasias, although we didn't see the entire skeletal system. Proteus syndrome, this may have been present in the individual known as the Elephant Man in 19th century London. This also presents with emphysema or cysts. It's typically unilateral or at least asymmetric. In addition to lung disease, patients get soft tissue overgrowth. It's actually characterized by soft tissue and osseous overgrowth more than disease in the lung. We saw the soft tissue enlargement, but not any bone enlargement in this particular individual, at least according to the images that were provided. And they can also get pulmonary embolism. We didn't have a CTA, but we might want to look for pulmonary embolism because they're susceptible to DVT and PE. And Brett Elliker, who's my former fellow and provided this case, I assumed he was going to give me really easy cases because I was really nice to him when I was his program director. But this one didn't seem that easy. But I would go with Proteus syndrome.
Thank you. Well, Brett gave me this case, and he highly respects you, but he didn't give me any easy cases. But you worked this out beautifully, and the correct diagnosis is Proteus syndrome. Great job. So this is a congenital disorder. It's overgrowth of tissues, soft tissues, bones, including lung tissue. It's normally, these people have a normal appearance at birth, but this is progressive afterwards, unfortunately. It does have a heterogeneous kind of mosaic distribution, so it tends to be more unilateral or at least asymmetric rather than many of the birth disorders, which generally are symmetric and diffuse. This is, again, more patchy. Most common organs affected include skin, musculoskeletal system, and vascular malformations. The pulmonary findings include emphysema and bulla, as we showed the emphysema here. It's often unilateral or strikingly asymmetric. Can be bilateral, but usually not symmetric, and although it can be bilateral. Hyperinflation with compression of normal mediastinal structures, as you showed, and there can be vascular anomalies and thromboembolism. So beautifully done case. And this brings us to the end of the unknown case panel, and I want to congratulate all of our panelists. They were brilliant. Thank you very much, and thanks to the audience for your patience and interest in these cases.